As you can see that we have a lot of variance in our thought process. But I'll just summarize on the neurological manifestations in Wilson's disease. The reason why I'm summarizing is that the onset of the neurological manifestation can start at the beginning of the second decade or the end of the first decade. And the typical manifestation can be divided into 3 groups or 4 groups depending upon various studies. The predominant complaints that we see is that dystonia, where a patient can have dystonia of the limb or the dystonia of the neck or dystonia of, it's an abnormal posturing of a group of muscles, abnormal contraction, sustained contraction of a group of muscles, and dystonia can be quite severe, making it difficult to swallow or speak. Or, even the change in the handwriting which is initially seen in some of the patients is actually because of a dystonia. The second group of disorders is Parkinsonism, where the patient develops slowness along with slowness in all kinds of activities, and tremor, which is a typical wing beating tremor that is described in Wilson's disease, and ataxic or choric form. Myoclonus seizures, autonomic disturbances can also occur rarely. Headache is supposed to be the most common neurological manifestation. Now, it's important to evaluate for all neurological signs in patients with Wilson's disease. Now, we've known that if a hepatologist sees a Wilson's disease patient, the first drug of choice is going to be D-penicillamine. And one of the reasons why probably you need to really look for a neurological manifestation is that if we have neuro-Wilsons, we go quite slow on starting D-penicillamine. So there is a guideline which suggests that probably you should do an MRI brain, as has been described previously. If you have an MRI brain lesions, the chance of neurological deterioration after D-penicillamine is going to be high. So it may be better to get an MRI brain in all patients with Wilson's disease, at least, to see whether there is MRI lesions, and then decide upon starting either zinc or starting D-penicillamine, or starting D-penicillamine on a slower note. So these are the guidelines which has been given in EASL and ASLD. Both have actually suggested that MRI brain should be done. Now, the MRI brain lesions, as Dr. Sinha has already shown us, can be varied. But in a patient with neurological Wilson's, you will invariably find MRI lesions. That is, T2 hyperintensities will be seen in a patient with Wilson's disease. It's very rare that you can have a neurological Wilson's without without any MRI changes. If the MRI is normal, most of the time the dictum to our residents or to us is that you have to think of a differential diagnosis. It's probably not Wilson's. A KF ring and a normal, absent KF ring and an absent MRI is suggestive that it could be a different disease. Now, once we have a neurological abnormality, then we need to decide on how severe it is. Or, there are only few scales which are available, which have actually come recently in the last decade, which are just, to grade or to see whether there's an improvement or not. This is known staging, where it is just divided into 3 staging: stage 1, stage 2, stage 3, based upon the activities of daily living, which stage 3 is completely bedridden, and stage 1 is fairly normal with mild or no functional impairment. This is a staging which is given by Chu N.S. And the other stagings which are actually well described, what we are following currently is the stage which has been given by Anu Agarwal and Dr. Mohit Bhatt, where global assessment scale for Wilson's disease, which is a 2-tier system. The tier 1 gives a global disability in 4 domains, which is a simple disability format, which gives it 4 domains of liver, cognition and behavior, motor and osteomuscular. But the tier 2 has a very detailed neurological assessment, which consists of 56 points, and it covers most of the neurological manifestations, and it can be summed up. Similarly, you have another rating scale which has been developed by the Euro-Wilson's Consortium, which is a unified Wilson's rating scale. And here, in this scale, actually they included a scale which is like Barthel's index, which is activities of daily living scale. And they have also taken parts of the unified Parkinson's disease rating scale, which is actually a scale for evaluating Parkinsonism. They've used a part of ataxia scale, that is the ICARS, and they've used a scale for dystonia. So they've actually combined the 3 prominent features and they put a scale in. Now, how do we know whether the patient is improving? It's a little difficult. Most of us monitor our patients based only on a clinical improvement of the neurological condition. So zinc, in case of patient with neurological Wilson, we start the patient on zinc. We can actually start, this is a lot of places which is followed, that we start, if the patient has got a very severe neurological condition, we usually start the patient on zinc, typically for 3 months, then add D-penicillamine. It can be started immediately, but what we have seen is that once you add D-penicillamine, after you give a good zinc therapy, the worsening is less, and you can probably accelerate the use of D-penicillamine a little bit more faster. You have to monitor for worsening on D-penicillamine. If there is a worsening, you reduce the rate of titration, and you look for reversal of neurological changes. Normally when we reach up to the level of, this is what we follow at NIMS Hyderabad. So each institute has its own different format. So what we do is that we continue increasing the level of D-penicillamine, and once a patient receives a good amount of D-penicillamine, that is 1 gram of D-penicillamine, this is in an adult patient, we actually start tapering off or stop the zinc and continue the patient on D-penicillamine. 70% of the neurological changes revert back after 2 to 3 years of therapy. So how do you monitor a neurological improvement? We base it only on the clinical improvement. And most of our patients will actually tell them it is quite dramatic, and most of the neurological symptoms improve, and their activities of daily living definitely improves. So that's only way of monitoring neurological improvement in our patients. I mean, it is there is no direct correlation between the amount of decoppering that we do and the improvement that happens. It happens that once you decopper to a certain extent, the patient starts improving. But a complete improvement of neurological signs doesn't mean that the patient is decoppered enough. So obviously you have to continue following up for 24-hour urinary copper, and which is in the initial stage can be a sign of good compliance, because you need to check whether they are there, and if the symptoms are not improving, we actually check it. Serum copper, ceruloplasmin, non-ceruloplasmin bound, free copper, all has been described before. They are affected by various factors, and so we are not really sure whether how much of it will help us. But the other test that we normally have to do is a follow-up for the liver function. And this has happened quite a number of times that the patient has improved neurologically, but the patient is worsening on the hepatic functions and develops cirrhosis on a long-term basis, even though the patient is well maintained on a low dose of penicillin. So it's important that for a neurologist, it's important that they look at the other sides of other parts of the body. Presence of necrosis or cystic changes on MRI, as Dr. Sandeep Sinha has said, is a poor prognostic marker of recovery, and it can usually, even from this stage, patients, there are reports where patients have improved clinically, but the cystic changes remain on the MRI, they don't improve. Dystonia and contractures can occur. Sometimes the neurological, if after 2 or 3 years of proper decoupling therapy, even if they have persistent abnormalities, then symptomatic treatment has to be given in various manner. And neuropsychiatric manifestations can still persist. And one of the reasons that we have seen non-compliance is probably because of psychiatric manifestations, especially in adolescents, where they refuse to take medication in spite of being told that they have to take medication. Thank you.
My basic question to all, where do you put zinc? Is it a chelator? Is zinc is a chelator? So far we are listening 3 drugs. D-penicillamine, triantine, zinc, all are in the chelator. To best of my knowledge, zinc is not a chelator. Zinc prevents the absorption of copper. Zinc probably, we are not sure, probably stimulate metallothionein in the liver that will trap copper. But zinc will not carry the copper or chelate the copper from the liver. So when you are talking about treating a disease, especially I am talking about the liver disease, where liver is full of copper, you want to remove those copper from the liver. So where from to start with liver and dependent zinc combination comes from. Secondly, we have 24 hours in a day, 8 hours for sleep. Exactly. You have 18 hours left. You have to have 3 to 4 meals. You have to take 3 doses of zinc. You have to take 3 doses of D-pen. And all these 3 are not compatible to each other.
Great.
You have to separate them out. Think about a patient who has to take all these 3 medication plus food, 9 complete in 18 hours time. If you combine any of this, and that will interfere their action and absorption.
The first question was why we should treat with zinc when it is directly not a chelator. So basically, as we know in Wilson disease, it's related to free copper or copper getting it. The point is we want to reduce the copper which is going inside the body. So the point is we give zinc which reduces the absorption, and zinc whatever is copper which is getting reduce the absorption of the copper, and everything goes out of the body without getting absorbed. Some amount of benefit with protection to liver is there. So that is how zinc works without the side effects of penicillamine. So there is a role which has been proved, and we have seen that prospectively it works out. Asymptomatic patients, they never require D-penicillamine. Symptomatic patients will take. Second part of the question. Now, second part of the question was zinc and penicillamine, why we should give it. It's all is called as fate, and many times we learn what happens, and sometimes we stick on to it. Most of the times what we read in the institute, what happens, penicillamine is a costly drug. We can't give full dosage medications. And what happens when we start giving a lower dosage medications, then we try to mix and match with the things. Penicillamine is chelating out, whatever is copper, it is throwing out with a smaller dosage what we are given. Zinc is trying to protect it, to avoid the further absorption of copper into the body. So the point is, yes, it's a complex, the way a patient has to take it, but when there is no options left over, when you start trying out something, things starts working in a good direction with 1 tablet and 2 tablets of penicillamine as against the full dosage of penicillamine which is not being given. If it is working out, most of the time we stick to that. That is why each institutes are practicing differently based upon the circumstances around which the therapies have been formed. Some institutes where in private practice, where costing is not at all a factor, people are not worried. We just stick to the penicillamine. Please take penicillamine lifelong. Whatever happens, we don't stop penicillamine, we'll tell them. But where there are other circumstances, how things have been changed. And that has taught us a lesson that, yes, this does also work. So that is where the concept of different therapies are there at different centers. Anyone else, please can add on to this.
Yeah, I can just add that we will use the combination, or I would use the combination only where, as he said, the patient can't afford the full dose of penicillamine, I want to cut down the dose, or adverse effects of penicillamine, where again I want to cut down, but not as a choice of first therapy. Not as a first line. No, I would
So
not.
the question is, to answer your questions, you use the way you want, we will use the way you want, because there is no consensus.
That's
Second,
what is the point.
the important point is, if you are talking, the whole, no, you have no evidence to say yours is better than mine, I have no evidence to say. Exactly. The point is, if you are saying chelators are necessary to remove copper from the liver, your whole reason why you are starting chelators is wrong. The hepatic copper will not reduce for 5 years, believe me. You are not reducing that. You are causing a negative copper balance in your body, which zinc does. It does. Zinc alone on its own does. So the whole mechanism is different. Absolutely agreed. There is no evidence one way or the other. I re-looked at the paper which was presented just now. The paper which you presented, the conclusions are very, very clear of the authors that this cannot be used as a comparison. You can do what you want. Please look into the matter. So there is no evidence whichever way it is. That is fine. I am not forcing you. We will not have a consensus. The whole world has not got a consensus. So where are we going to get the data?
I think only way to get the answers, whatever consensus are there, whichever the centers means there need to be, only way to come is a prospective observatory study, which each centers are doing. What is helping out better, both biochemically and clinically. That's the only way to look forward.
Actually, because neurologists, we feel that we should give penicillamine slowly, and I think that is a consensus amongst all neurologists. We start with 1 tablet a day, 250 milligram, even sometimes even half a tablet a day if it is a tablet or a capsule. But the point is that what we do is that we give 2 times zinc. It's not that we give, that is what we do. We give BD and we give BD penicillamine. BD, both BD. So that's why it's not 4 times a day before meals. It makes them easier. I agree with you, sir. I agree with you, sir. So we give 2 tablets and then 2 tablets.
Sure, please go ahead.
Dr. Ashish and Dr. Thapa, Dr. Seema, all your pediatric GI people, what will be your drug of choice for induction therapy? First drug.
For which? Penicillamine with or without zinc?
With or without zinc. Fine.
Penicillamine is a must.
Okay, fine. That's agreed. Second thing is for the neurologist, a simple thing which you have to satisfy without ambiguity. A child whom we have started on D-penicillamine had no neurological manifestation at the beginning, only hepatic problem. Over a chronic use of this D-penicillamine, this patient is improving liver-wise, but has developed now neurological symptoms, certain signs. There is dystonia, there is some slurring of the speech. What should we do at that point of time?
That means patient is not responding.
That
Penicillamine
patient is not responding.
Yeah, penicillamine is
Okay.
not working.
Wilson disease is a disease.
Yeah, fine.
It cannot happen that liver is.
Exactly,
Okay.
or not compliant.
Hey, Ashish,
Not
give it to
compliant.
him. This mic.
Yeah.
Okay, so,
Either we increase the existing dose or add zinc.
no, first is that we have to check the compliance. Is the
Those are
compliance
sorted out.
good?
Those compliance, all issues have been sorted out.
So what
If
is the
the
second step
patient
you said? What
If
is-
the patient has stable hepatic or improving hepatic and now develops neurological, that means the existing treatment is inadequate. So
Okay.
either we have to increase the drug dose or add another one. There is no
Okay,
controversy in
fine,
that.
fine. Thank you, thank you.
Coming to neurology, if the patient has not very severe form, at our center, we start both zinc and penicillamine. Whenever we start penicillamine, whether it is severe form or not severe form, we start it very slowly and
means-
build it over months.
No, it means, sir,
Dr.
one
Yacha.
point, one clarification I want from you, sir. It means that if the patient is on depenicillamine therapy and he is not taking adequate doses or his dosage is not appropriate for that age, suppose the dosage is good, you mean to say it is because of the inadequacy of the
Yes.
treatment or it is a natural process of
No
the
sir,
disease?
it
Inadequacy of
doesn't,
treatment.
not natural process, inadequate treatment.
Inadequate.
Inadequacy of
So we are clear about it. Thank you.
Now, what did he say, that the inadequate doses?
Yes, sir.
Yes.
No, what I am just want to say, that Dr. Yacha has raised a very valid question, that you have started the D-penicillamine 1 to 2 grams per day to a person.
No, he has not told 1 to 2 gram. What he told.
No, I said adequate dose, he is doing well otherwise.
And
Now he has come with a
this-
neurological
this
deterioration
situation-
for the first time.
So
For
usually,
the first time.
Then I will add zinc.
Adequate.
Then I will add zinc.
No.
It's an inadequate treatment.
Sir, he has raised a very valid question, whether the patient is taking the drug or not. Won't you
that is-
clarify?
that-
Okay.
that
Why
is
won't
first
you
only-
clarify that he is taking the
No,
adequate?
I understood that he has already clarified the compliance issue.
I think the first thing should be that whether he is taking.
Compliance.
That is very standard. First is
Your
compliance issue has to be,
So how we would say that he is taking the adequate doses? How would he sort out the compliance issue in that patient?
urinary copper, that's a
and,
standard.
So if he is
practice.
taking, then you will add the zinc.
Yeah, naturally. Those things are standard practice.
Right, sir.
I think we didn't answer the question what he asked initially, when zinc is not a chelator, why to give it? So, from where the zinc is coming? It's coming from the intestine, what we are eating. So it makes a common sense that you reduce the absorption of zinc first. Second point is, the zinc which is already been deposited in the body, you chelate. Copper. So that's why zinc is required to reduce the absorption first. That's a very, simple thing. So first you reduce the supply and then also the chelate copper from the body. So I completely agree, it's not, and I don't know how we define chelation. So anything which will come out of the body will be chelation only. Copper is also chelating it from intestine, but the method may be different.
No.
Sorry, zinc is chelating.
Just a big thank you to all the faculty and all the people who are waiting till the very end. We could go on for another day with this, and hopefully tomorrow we should come out with a consensus of the INSL, which should be published in the journal, hopefully, which should be soon published in the journal. I think that's it. Thank you all very much on behalf of the organizing team over here. Thank you all.